Yeah, so I was saying that they started like presenting here started after a conversation with some of the colleagues in the critical care OR and cardiology at St. Mike's to try to get a little bit of a glimpse of how we're using resuscitative TE. So nothing to disclose. So the idea is to go over what's the role of TE outside of the cardiac wards, in our case, for cardiac anesthesiologists, and also in terms of the resuscitation during cardiopulmonary. I just want to acknowledge some of you might know, especially that San Mike through this was Jorge was my mentor, and he was instrumental in my training at San Mike Hospital as a cardiac anesthesia fellow. And fortunately, he passed away a few years ago, but you have very fond memories of him. So the idea is to try to bring the idea of using transesophageal echo as point of care ultrasound. So point of care ultrasound has been evolving for the last few years, and I would say for the last 5 to 10 years, kind of exploded given the fact that there's easier, more affordable devices that were better ways of training and certification. And in my case specifically, I became very interested in this because of my IMG journey and way of training. I was an intensivist before as an anesthesiologist and a cardiac anesthesiologist. So I learned point of care ultrasound and echo a few years ago together. By the time Alberto Goffi, so you might know, who is in St. Mike's, me and Alberto were ICU fellows when we got here to Toronto back in the 2010s, and started becoming very interested in echo and POCUS, and we developed a few things. And now, and after that, when I started my anesthesia and cardiac anesthesia training, I kind of realized the power of transesophageal echo to bring it as a part of the POCUS. So interesting. There's some literature that's been talking about that for a few years now. And if you look at this review paper from 2019, where they kind of go over like how the role of point of care ultrasound has evolved in critical care medicine, emergency medicine, and like any other acute care specialty, they go over a few things. And one of the things they mentioned for critical care echo is that every ICU must have or should have a PE Pro that they can use for resuscitative purposes. And this is published by mostly people in Europe. And I would say the development and the implementation of resuscitative T in Europe has been faster than North America, but now in the US, there are a few places, and now even in Canada, a few places as well. And one of the problems is the nomenclature, right? That we still don't have very clear definitions and outlinings of. There's so many variation of definition in point of care ultrasound, and even more in PE. So that's why this group of people here put up this nice paper together where they included the American Society of Echo, the American Society of Emergency Medicine, the Society of Critical Care Medicine, the Society of Cardiac Anesthesia, and many others, including even the American Society of Radiology and Ultrasound, to try to put together some ideas of how to unify and how to speak the same language in terms of point of care ultrasound, and clearly define what is basic point of care ultrasound, what is advanced point of care ultrasound, and so on. And resuscitative TE is becoming more and more part of what's now been defined as advanced point of care ultrasound for critical care and emergency medicine and anesthesia. And if you look, in fact, how much of point of care ultrasound is being used in critical care and other areas outside of the traditional echo lab setting, this study is from the UK, which I would say is the largest study that looked at this question of how much ultrasound is being used. Still, like about like only 45% of the patients who are in the ICU have received some form of echo, and in this study they even include not only like echo and point of care ultrasound done by the primary providers like the intensivists, but also in terms of used by or cardiologists as a consultant for come and do an echo and then reporting the results. So it's still quite a bit of room for improvement if we believe this is something that will help our patients. So in terms of PE specifically, there's still no very clear definition of what is the resuscitative PE. In the anesthesia world, we have what's called there's two ways of or two pathways for the certification according to the National Board of Echo, which is the basic perioperative TE and the advanced perioperative TE. Traditionally, the advanced perioperative TE is the one that we do in the cardiac OR, where we do 28 views, all sorts of measurements with Doppler, even strain, 3D, and so on. And there's a more comprehensive basic TE exam that it complies of 11 views with less terms of measurement. But in terms of resuscitative TE, we don't really have a consensus of what actually defined. So overall, the consensus, or what I would say is where more people have been using it, from those 11 views that are included in the basic periop TE, use 4 to 5 views similar to the basic POCUS, right, which include the peritoneal long, the peritoneal short, the subcostal view, and the apical four. So it's kind of the same idea of using 4 to 5 views, using only the metasophageal port chamber, the metasophageal long axis, the transgastric short axis, and the bicable as basic views to try to answer questions for patients who are in severe shock, severe hypoxemia, or in cardiac arrest. So most of the groups, although there's no clear definition of consensus, that's how they've been implemented and developing their different protocols for using the resuscitative TE. The way that I see it is I'm a huge rock fan, and this is one of my favorite albums from the 90s, from Nine Inch Nails, is called The Downward Spiral. And the way that I see it is when you're in a downward spiral in a situation, either in emerge, in the ICU, in the ward, or in the OR, that patient is in severe shock, severe hypoxemic, and is not really responding to the traditional or the conventional management, there has to be something else happening. And that's what I think he has a role in trying to identify these possible causes and help guide your treatment. And we have a few studies looking at this. This is probably the first one that is published a few years ago in a group at a Mass General Hospital, where they formed this rescue team in the ORs by some of the cardiac anesthesia fellows and the cardiac anesthesia attendants, and they developed this thing for other people to call when they were in a situation of severe shock or severe hypoxemia, and they would go and using all those simple 5 views, they would try to identify what was going on. And after collecting the data for almost 50 patients, they realized that they noticed that it was a change in the treatment of this patient in about 70% of the cases after the information that was obtained from the resuscitative TE. A larger study done here in Western Ontario and in London, and more recent, look at kind of the same question, but now in ICU patients, in critical care patients, where close to 300 patients, they look at using only these 4 basic views to identify what was the outcome in terms of diagnosis and management. And again, they found that in about 2/3 of the patients, there was a change in the management according to the information that was obtained from the resuscitative TE. And this same group in London, they looked at even specifically at the population of trauma patients, which are similar to, for example, St. Mike's and Sunnybrook, which are the two large or are the two trauma centers here in the city, in the Toronto area, where we looked at a lot of this critical injury patients. And they look again that only at this specific population, they also noticed, or they shown that in about 2/3 of the patients, there was a change in the management, and there was new diagnosis and new strategies used for the resuscitation or the ongoing management of the patients. And it's interesting because in this study, there were no surgical patients. There were no patients in the OR. They were either in the ICU or in the emergency department where they would do the resuscitative TE to try to manage the patient. And this is what led us to, specifically for us at Sunnybrook, we developed a resuscitative TE protocol specifically for trauma patients that we routinely use in our place and mostly in the ORs, like outside of the cardiac ORs. And now we've expanded the use of the ICU, where if they're critical care teams, they feel that there might be a use for resuscitative TE, we go and do them as well. And this is part of the reason is because of this. Like, although I'm a huge believer in POCUS, like a lot of times this is what we see, specifically in critical care patients, right? Like where they're on positive pressure, their position is not optimal, their body habit is not optimal. So we need to find a tool that will try to overcome these obstacles that we commonly see in this type of population. And in fact, a good review of strategies for difficult patients to be scanned or difficult patients to obtain echocardiography in the ICU was published earlier this year. And if you look at there's all sorts of different strategies that you can try to optimize and try to use more of the subcostal view and all the modified views that you can obtain from the subcostal. But at the end, if there's nothing that really works, like all the pathways take you to, well, then consider using a TE probe to try to obtain the information. So I'm just going to present a few cases on try to illustrate how has this helped in our experience specifically. And in fact, this was my first resuscitative TE that was done when I was a fellow at my hospital a few years ago. And there's a patient who was having an elective infection, and after delivering the baby, went into cardiac arrest, which was quite unusual because there was no clear reason, clear sources like bleeding or high spinal anesthetic or other reasons. And it was a previously healthy patient with no significant medical history during pregnancy. And after 3 rounds of CPR and ACLS, they were not obtaining RUS, so they called if we could help with the probe, and we went into the OB like the labor and delivery ORs, and put a TE probe, and this is what we saw, which led us to think that this was quite a clear RV dysfunction, dilation, and what we could even suspect that there was some even content inside the RV cavity, which led to the diagnosis of possible amniotic fluid embolism. This patient kept being resuscitated, eventually got ROS, went to the ICU, and eventually went well. But there's other cases which have led us to change the manage. This was a patient which would had at our OR a couple of years ago, where had a elective or semi-elective because of cancer surgery, mastectomy, and uneventful procedure. Went to the POCUS, the recovery area, started becoming a little bit hypotensive and hypoxemic. Got given some fluids, given some phenylephrine. Did not improve. Went into cardiac arrest, and after a few rounds of CPR, we tried to do like transthoracic POCUS, but we couldn't really see much of a view. So we put a TE probe, and similar, we saw severe RV dysfunction with dilated RV and other real causes of the arrest. So led us to think that this could be explained because of a massive pulmonary embolism, which made us take the decision of give IV thrombolytic, which in another scenario would have been very challenging to decide given IV thrombolytic to somebody who just coming out of a major surgical procedure, because obviously administering the thrombolytic is going to lead to bleeding. But having this less uncertainty in terms of the diagnosis gave us more confidence to make the decision and eventually improve and got ROS after given the thrombolytic. And this is another patient, a trauma patient who was involved in a motorcycle accident, but mostly MSK injuries, no significant head injury, C-spine injury, or abdominal injury other than MSK injury and blunt chest trauma, and was quite hypertensive in the unit with no clear source, like no signs of bleeding, no evidence of the tamponade or anything else, no very good views. And they asked for resuscitative, and interested enough, we look at a more focused view in the aortic valve. You can see that there's an avulsion of the leaflet causing like wide open aortic regurgitation, quite unusual. And after chest trauma, because it was like an isolated injury to the aortic valve with no involvement of the root or no other traumatic aortic tear, which is what you commonly see in this type of patients. But obviously, having this diagnosis then led to improve the management of these AI. And eventually, after he recovered from all his injuries, he went for aortic valve replacement. And this is a very compelling and humbling study, because the patient who was in the unit after a complicated course of hepatectomy for cancer that didn't go well in the initial post-op days, had some bleeding, and eventually got into a septic shock and went into the ICU to become like reintubated and being treated for sepsis. And at some point, they decided to take this patient to the operating room for a further washout. And I was the anesthesiologist. And when I went to the ICU, I noticed that he's in every single pressor you can think of at very high doses, including like inhaled nitric oxide. And it was interesting to me that nobody has done an echo, or at least they tried and they couldn't see anything. So I was very uncomfortable of taking the patient to the operating room, not really knowing what was the cause, why was the patient in such a severe degree of shock on such a high doses of epi and doses of or epi, like even dobutamine, that they were thinking that he had some degree of RV failure as a component of the shock. And when I put the probe in, you can clearly see that there is like even without using any Doppler measurement, you can see that the anterior leaflet of the aortic, the mitral valve, is getting sucked into the LVOT, causing likely SAM and dynamic LVOT obstruction. And if you amplify and zoom in, now you can demonstrate that there's clear acceleration of flow, dynamic LVOT obstruction with SAM and posteriorly directed MRJ, which change your management completely. Like so there was some of the treatment that is being done for the patients which are actually contradictory to what you should do.
After declaring that I was going to run,
in terms of
people oftentimes ask me, "Why don't you run the Trump?" And I would say, and then on several occasions, I was approached by.
So anyway, that led us to change completely the management of this patient. And in fact, after changing, we put back the patient back to the ICU after a washout and minimal amount of pressors and a very, very resuscitative condition. And more recently, a case from this year, the patient who had a fall, broke his pelvis, no other injuries, goes to the OR for his pelvis fixation. And after the induction and moving the patient from the stretcher to the OR table, goes into cardiac arrest. Not really responding to the resuscitation, so they called for the TE probe. And this is just during the CPR, just to illustrate another very important point that we'll go over in detail a bit. But after putting the probe, we can now clearly demonstrate that there's massive amount of what looks to be clot in transit in the RV and into the PA. And having this diagnosis changed completely the management, because this patient was actually quite lucky that it happened in the middle of the day with a lot of people around. So having this diagnosis, we were able to call the cardiac surgeons immediately and the people that thromboembolic service immediately to try to decide what would be the best course for this patient, and we decided to do a crash sternotomy and a thrombectomy. And this is what they actually got out of both the pulmonary arteries, and this patient was able to survive after a couple of weeks in the ICU and left hospital home without any type of sequelae. So that lets me to switch a little bit of a gear in terms of what's the actual role during cardiopulmonary resuscitation. And POCUS has been part of the guidelines for ACLS for a few years. Initially, a lot of enthusiasm because as anything or any new technology comes in, everybody's very excited about it. Unfortunately, after a few years using it, what we start realizing is that because of that excitement, people would stop CPR or would interrupt CPR or would delay the resumption of CPR because trying to get images. So it's very important to always remind that if you're doing point of care ultrasound during CPR, never interrupt or delay the basic intervention, such as CPR, defibrillation, and the shockable rhythm, because at the end of the day, those are the two only interventions that actually shown that help the outcomes of these patients. But if you go back in history, it's interesting that a lot of the physiology that was described in terms of coronary flow and blood flow during cardiopulmonary resuscitation is done. Some of that work was done transesophageal echo and very rudimentary images that you can see in those pictures. And the use of TE also might mitigate that same obstacle of interrupting or delaying basic interventions. And this study showed, this was a study done by emergency physicians, where they recorded, like video recorded resuscitations, where they used in a group, they were using transthoracic subcostal views, and in another group, they were using resuscitative PE, and where they went back and reviewed the images of the recording, they noticed that in the fact in the TE group, because the probe is already in, you don't have to actually stop of compressions or delay compressions. There's a clear benefit that might mitigate that problem that we see we have transthoracic. So what's the actual role? So we can use it for either diagnosis, like we can find for the causes of the shock or the cardiac arrest, like we saw in the few cases that I presented. We can enhance the quality of CPR, which is what I'll describe now. And we can also use it for as a guide for procedures. Nowadays, there's more and more. There's a better described role of ECLS during cardiac arrest, or eCPR. T becomes a mandatory tool to guide the resuscitation and guide the insertion of the cannulas and guide wires for the use of ECLS after cardiac arrest. But what is really, I think, has been a game changer is the concept of try to identify the area of maximal compression. And what this is that on real time, putting a TE probe and using the metaesophageal lung access view, you can see real time what the actual CPR is doing. And where is the CPR mechanically compressing the heart? Because after doing this for a few years, there's more and more data shown that a lot of the time that compression is being done in either the LVOT or the aortic valve itself, which is completely contradictory to what we want, because then there's no forward stroke volume, and the intention of providing CPR to provide flow is not happening. And we can do this real time. And this is actually a real case where in the image or the clip on the left, the CPR is ongoing. And you can clearly see how the LVOT and even the aortic valve is the area that is getting compressed instead of the free wall of both the RV and the LV. And in real time, we can reposition the hand and provide feedback and tell whoever's doing the compression that they need to reposition the hands and to actually do the CPR in the area of maximal compression. And you can even use like color flow Doppler to even illustrate the point even better, where you can demonstrate that from a situation of no flow across the aortic valve, you can go to a situation of flow across the aortic valve to demonstrate that the CPR is actually doing what it's supposed to be doing. And although a lot of the things being anecdotally described, now we have better data, initially from experimental studies from animals, which this study coming from, where they, in a swine model, they use real-time echo, and they use other hemodynamic parameters for quality of CPR that have been described from some time, as such as the end-tidal CO2 and the diastolic arterial pressure. And they were able to demonstrate that when there is LVOT obstruction, of course, there's going to be less, or the value, the numbers of diastolic arterial pressure are going to be way lower, and the end-tidal CO2 is going to be also lower, making the point that the compressions might not be as effective as we think. And this first observational study looked at patients who will come into the emergency department out of hospital cardiac arrest. They put in a probe in the emerge to use resuscitative TE. And it's interesting because in about 20% of these patients with ongoing CPR, they were able to identify that in about 23% of those patients, the compressions were actually being done in the LVOT, which led to a change of management immediately to switch it to a better area of maximum compression. And even a larger study published this year in Critical Care, where they looked at a patient, again, out of hospital cardiac arrest. They come in the emerge, they put a TE probe with ongoing CPR, and they were able to demonstrate that the patients where there was no compression of the aortic valve and no compression of the LVT had a better chance of ROSC, had a better chance or higher survival in the ICU. And we'll have to ask the question now of this is actually translating to longer or better outcomes in terms of patient survival or discharge from hospital. We don't know yet, but I think there's two large observational studies ongoing, recruiting patients, trying to answer this question. But I think overall, this could lead to a change in the way we do resuscitation, and led to even some protocols incorporate the use of resuscitation as a routine for resuscitation, like for cardiopulmonary resuscitation, if the first two cycles of CPR and basic ACLS are not successful. Now, is it easy to learn? Well, it is. We doing some data, some research about how easy to learn this resuscitative the same way of POCUS, and using simulation, using alliances with either cardiology or cardiac anesthesia, where trainees can spend some time in the either cardiac lab. They can become more confident of acquiring the views and interpreting the views. And now there's even pathways, clear pathways of how to train in resuscitative TE in the UK and some parts of Europe, and ongoing work to try to formalize the pathways in North America is on the work, and it's part of it now becoming part of the NBE certification for the critical care echo exam. And even in some countries, this is from Belgium, and what are their requirements for competence in terms of performing scans. And it shocked me when I saw it, because for resuscitative is even less amount of scans that you need to be you need to have your portfolio than, for example, gastric ultrasound, which is one of the easiest ultrasound to learn, and with a less challenging learning curve. A lot of times when we come and do these type of techniques, or try to take these traditional diagnostic tools, which traditionally has been done in certain areas, such as like the cardiac OR, for example, or the echo lab, we face a lot of resistance. And it was the same way when we started doing POCUS years ago. And you'll hear a lot of this. But while some people are focusing in try to make obstacles or have barriers, other people are actually taking it to a different level. And yes, I found this tweet earlier this year where there's places in Europe, again, that they're done where they're even thinking or they're using resuscitative even on the field by trained advanced either intensivists or advanced paramedics to improve the diagnosis and the use of ECPR in the field. So, I mean, the choice is yours. I think this is something that is going to change management of patients on the resuscitation and severe shock. And although this is not a key study, I would like to bring it because it's the first study that we look at using POCUS and this problem in terms of medical legal problems, because one of the resistance that we often hear is that, well, we're training a lot of people to start doing basic echo or basic POCUS that they might not have enough training and enough confidence to make diagnosis. There might be a lot of errors happening. So this actually study look at all the CMPA registry and try to identify which claims were associated with point of care ultrasound. And of course, this is a new technique, so the number of cases where POCUS was identified was matched is very low. But interesting enough, in about almost half of those cases, the problem or the claim was not because there was a misdiagnosis or there was an error. It was actually because there could have been the indication of a point of care ultrasound, which was not done. So at the end, I think the take-home message is, I think this is a diagnostic tool that is here to stay, the same way as the traditional point of care ultrasound. We're going to have more and more implementation of resuscitative out of the traditional areas. With the use of AI, this is going to become easier and better quality to implement and do. So I will leave you with this homework to start becoming more interested in the use of resuscitative PE, keeping always in mind, and this applies to any form of ultrasound, particularly in point of care ultrasound, that it is always a help for a clinical context. It's not as a magical tool, it has to be attached to clinical context, and not because we can do it, we should do it. Okay, it has to be always a clinical question that we're trying to answer, and we use the tool for it. So thank you very much again for the invitation. I'm happy to answer any questions and looking for further collaboration with everyone in the echo world to make this happen more and more in every single of our tertiary care centers.
So thank you, Pablo. So certainly we can appreciate a cardiac anesthesiologist and critical care expert like yourself has much better humor than many of our echocardiographers. So thank you. And I love the blue pill, red pill analogy from Matrix for those people are not old enough to recognize that. So just a thought about how to actually implement that. I see that the manpower could be an issue, especially outside, you know, the critical care environment or CICU, ICU, MSICU, you know, surgical ICU, that type of environment where you have often a machine parked there, then you can do the T quite easily with the machine there and then person power there. But how do you do this when you're actually having a code somewhere else in the hospital? Has there been any thoughts or studies that sort of help us with that logistic and finding the machine and the person to do it?
Yeah, no, that's an interesting question. And yeah, it's absolutely 100% true. Like that's part of the biggest challenge. And that's why all the studies done so far have been done either in very specific areas like cardiac arrest that come in the emergency department or in the operating room or in the ICUs. On the medical floor, I don't think there's been any study yet because, again, it's a location problem, as you properly pointed. However, I have to say that other than like manpower is a big issue, and that's one of the things that we really focus on. Like we've tried to train, for example, a few of our non-cardiac anesthesiologists to be able to do a resuscitative TE, because there's not always there is a cardiac anesthesiologist around, specifically after hours. So we've managed to train a group of like so far six of our non-cardiac anesthesiologists in resuscitative TE. The same way in the ICU, some of the intensivists are being trained in the resuscitative TE, and same with an emerge. So I think it's very important to make all this as an alliance. We've tried to have an alliance between the three groups, between the emerge, the critical care, and the OR, to share models of training, share models of quality improvement. We're working on unifying our image archive system. So far, we use the same archive system as the merge, so we can do some quality assurance between the two groups. And also in terms of equipment, we've managed to have like outside of the traditional full 3D machines that we use in the cardiac ward, we now have a few machines around, both in the three departments, who are POCUS machines, but they're capable of 100 TE Pro, so they're way more portable and user friendly, not as complex as the traditional machine.
Okay, Dr. Connolly has a question.
Hey, Pablo, thanks for the great talk. Yeah, I mean, I completely agree with everything you said. This is such a great modality to help in these cases that we often don't really know what we're doing, right? That's clear. The stethoscope is not used as frequently, whereas the ultrasound is going to be. So we can either get on board and figure out, or we will be going behind. One issue, when I tried to do this years ago in Australia, this was a long time back, and we actually had some issues with the TE probes being damaged during CPR. I'm wondering, have you had any issues with that? And I can't remember if the damage was because, you know, people just pulled it out and it got whacked on something, or if it was actually due to chest compressions or anything like that. And the crystals were actually damaged, so the probes were then not used afterwards. Have you seen anything like that, or is this basically just me showing my age and that it was 20 years ago when we did this?
Well, I wouldn't say that, but yeah, no, I haven't seen any of that. And another side of it, I always, every time that I give this lecture, there's always people always also ask if there's any increased risk for the patient, like for esophageal injury or esophageal perforation, of having a probe during CPR. And although it's a good thought to have and theoretical, there hasn't been any cases reported of such as well.
Yeah. Okay.
My experience with the trauma to the TE is mostly because of the in and out of the mouth area. Many people don't put in the mouth guard in this kind of situation, which when you go in and out, and the diaphragm can hit the teeth or teeth remnant. So that's actually the highest risk of actually damaging the probe when they start leaking. The mouth guard is always very important.
Yes.
Okay, any other questions from the local audience? Oh, Rudy has a question. Please go ahead.
Hi, Pablo. My name is Rudy. I'm one of the Echo fellows here. I'm just curious, how do you envision how trainees are taught with respect to, I guess, sort of like resuscitative transthoracic echo? Just, you know, I've only seen a few cases of sort of good resuscitative TE done in, you know, either the emerge setting or the ICU setting, or some clear area where there's infrastructure there. It's usually, you know, at least the cases that I've seen, it's been kind of like, you know, there's a second operator, there's a trainee with the second operator. It's kind of like a big deal to have the probe go in, you know, it takes up a lot of attention and time. And I can imagine the trainee going through, you want to spend, you know, you're interested in getting good skills with TE. That being said, you know, at least from my experience, a lot of the cases where we didn't have that, you know, there's someone who's very good at transthoracic at least, and is able to kind of quickly identify pathology. And, you know, going through my cardiology training, my training during codes and arrests was transthoracic, and being able to answer as many hemodynamic questions as I can with transthoracic. Do you feel that, obviously, the pictures are, excellent, and the quality of information you can get, especially during interest, is probably better with TE. Like how do you find trainees are taught now that this technology is here and there? Do you find that it takes away from, the sort of good cardiac POCUS from a transthoracic point of view? Do you find that this takes away from that kind of training for ICU and anesthesiology trainees?
Yeah, I mean, I don't think we're there yet. I think there's still like a lot of the training is being focused still in transthoracic. And even transthoracic is not something that you see a lot still. I think there's still a lot of work on and room for improvement. There's still many situations or many arrests or many severe shock situations where not even a transthoracic is done. So while the T nowadays is something that is more of being trained or being taught for a higher level of trainees, either fellows or younger staff. So I don't think we're there yet, but it certainly could happen at some point that it might take away from the transthoracic. But yeah, I don't see that happening yet. But I do agree that we should train more advanced or what we call resuscitationists in this technique, because I think it could be a game changer.